Hello, this is Dr. Robert Parker, and I'm happy to present to you today one of my favorite subjects and topics of the 12 steps to better nerves, and that is fear of falling, stumbling, what I call shades of drop foot. You know, there's a big movement in my profession today called fall prevention, but these are movements that are talking about splinting your ankle, what we call ankle foot orthoses, and these are devices such as the Ritchie brace and physical therapy treatments such as gait analysis and gait training. And all of these have made a great difference in our patients being able to avoid falling and injuring themselves. But today I'm going to tell you about a treatment that I've been doing for over a decade and a half and why you have this fear of falling and what my patients have coined as stumbling, catching a toe, or having a steppage or a paddle foot gait or a slap foot gait. These are all not normal. And I have found that in general neurology, general medicine, and even in my own profession of podiatric medicine, there's virtually no conversation about what you are about to learn today. These are critical discussions because if you fall, especially if you are up into the senior years, you may sustain fractures, wrist fractures, cranial fractures, and one of the most common is fracturing a hip, and then having to have hip surgery, be admitted to the hospital, and 1 out of every 4 that are admitted to the hospital that are elderly do not come out of the hospital. In other words, they die of pneumonia or something of the sort in the hospital. And I recently described this situation to a patient of mine, and she said, "You're describing exactly what happened to my father." And she did not want to go down the same path. So let's discuss exactly what's happening in this scenario. The large nerve in your lower extremity going to your lower leg that lifts your foot up and out is called the common fibular nerve. This nerve is frequently entrapped in peripheral neuropathy and causes not only sensory changes such as burning and tingling down the outside front of your lower leg and foot, but it also causes motor weakness because this nerve is what we call a mixed nerve. And this means that it affects your sensory, your ability to feel things, and your motor function, your ability to move things to your lower leg. Now, there are numerous reasons for this nerve to be affected. The most common are 2, trauma and systemic causes. In trauma, such as sports injuries or occupational, the nerve gets impinged or directly injured because it's so superficial, just below your knee on the outer upper calf, and it's easily traumatized. And systemic means some disease or disorder such as diabetes, which is the most common. But then there are other unusual disorders such as vasculitis and leprosy, which fortunately we don't see a lot of in this country. So in the traumatic category, sports injuries, occupational, and habits, habitual leg crossing is one that can cause compression against this nerve, particularly if you are crossing your legs in the same manner, and usually this affects one extremity more than the other. And I previously mentioned an injury while playing sports, such as soccer or football, where a hard object might actually strike the nerve directly. And historically, a cast that is applied too high on the lower extremity can compress against this nerve and create a drop foot. Also, chronic postural squatting positions, such as individuals who are playing sports like catchers in baseball, or strawberry pickers or rice pickers in the field where they're squatting down for hours on end, can develop what we call a palsy, which is a partial or complete paralyzing of the ability for the muscles to move, and thereby the name strawberry picker's palsy. But by far, this slide presents the most common reason why we have this partial drop foot or complete drop foot, and that is from the systemic results of a person being a diabetic or perhaps they are pre-diabetic, and the same process is going on. Let me explain. In this schematic, if you look at the upper outer light blue or turquoise portion, it states pre-diabetic peripheral nerve, where glucose changes to sorbitol. Sorbitol is a reduction of glucose to another sugar, and that sugar is hydrophilic. Hydrophilic simply means that water is drawn into the nerve. And you will learn in my office the concept of fibro-osseous tunnels, and there are many of these in the lower extremity, but primarily three. One that we've been discussing here, the fibular tunnel, in the upper outside of your calf. Secondly, on the inside and back of your ankle, called the tarsal tunnel. And then we have on the very top of the foot, the dorsal midfoot deep fibular nerve tunnel. And I like to give the analogy of injuring your ring finger and being in the emergency room, and your finger is so swollen that the ring must be cut off for fear of actually losing your finger if it's left there. Everybody understands that principle. The principle applies here when the nerves swell by 50% from that glucose changing to sorbitol, and the nerve swelling by 50% represented with the blue image on this slide. Then you are getting a compression in effect at those fibro-osseous tunnels. So remember that when the nerves get compressed for any length of time, like the gradual onset of diabetes or trauma that's developing scar tissue around the nerve, on this slide, you start to get a subtle drop foot. Because the myelin sheath that surrounds our nerves and protects the nerves, like insulation around the electrical wiring in your home, and this is represented beautifully in the upper outside square, where it shows a good, healthy myelin sheath around the nerve. And then as the middle picture shows a withering away of the myelin sheath down to the very bottom image, where the nerve has shriveled up with less circulation from the nerve being choked off from the nutrients it should be receiving from the circulation. And so that you can get a better understanding of where these compression sites affecting your balance and gait is pictured in this slide. To the left, you see the most common compression sites, and you'll see the common peroneal nerve, which is now called the common fibular nerve that we've been speaking about, supplying the entire outside and front of your lower extremity. The superficial peroneal or superficial fibular nerve, the second circle down the lower leg there, is another site of compression, as well as in the dorsal midfoot that you see the very low circle. The middle slide shows the small incision made over the upper calf, where I make my incision to open up the fibrous compressing structures of this nerve. Almost everyone has heard of or understands carpal tunnel syndrome. This procedure is almost identical to carpal tunnel, with the exception that carpal tunnel is simply one ligament, and this one has several areas of compression that need to be freed up so the nerve can start functioning again with what we call axioplasmic flow, which are the proteins going up and down the nerve to cause it to work properly. Now, I am very excited to show you some of the patients that we have done these procedures for with various causes, or what we call etiology, and the first being a young lady who had a compression or damage to her nerve when she fell downstairs. She was referred to me by an orthopedic surgeon who is an upper extremity surgeon, and I'll let you hear her story, and then we'll move on to the next 5 or 6 patients describing their stories so that you can see just how powerful these procedures can be in regaining strength, balance, allowing these people to get rid of their canes, ankle-foot orthoses, and walk more normally as a result of this wonderful procedure. Here are their stories. We have Jennifer Watson back, and today is 5/11/2010. And Jennifer had her decompression of the common peroneal on the right extremity. She was referred by Dr. Palumbo, an orthopedist, who diagnosed her with drop foot, and she had weak extensors on her hallux. And so now we are, 2 months out? Mm-hmm. We're 2 months after your surgery. So, Jennifer, would you briefly just describe what you originally experienced, how it happened, and so forth, and then we can kind of look and see how your strength has changed today.
Well, my foot was kind of like a dead foot. When I walked, I couldn't lift it up completely, and then from there it got worse in November, December area, and it was numb right here, mm-hmm. and it would build up and feel really tight and heavy, mm-hmm. and it was weak. It was probably like that, I don't know, something, mm-hmm. and it's not like that anymore.
Good, that's wonderful. Well, I'm so happy now. So let's go ahead and lift both your feet up together. Perfect. You have good strength. Now I'm just going to try to pull your big toe down. Hold it up for me. See, that's nice and strong. Before, I could just go push it down very, very. So she's got a good, they're both equal now, actually. Both good strength. And then also, I'm going to try to pull down on your foot. Very, very nice strength on that. And then, again, you were having what we call paresthesias. You were having tingling, numbness, and everything. Was it down mostly the front of the calf and into the top of the foot, both of these?
Mm-hmm. It was
right in there. Mm-hmm. Okay. And so now when you're walking, you're not experiencing that steppage or slap. Mm-hmm. Okay, good. Thank you, Jennifer. Yeah. Andy Liu is in today, and Andy has a running injury that's what was sustained a little over a month ago, mm-hmm. and at this point he has loss of his ability to dorsiflex the right foot. Andy, would you go ahead and attempt to lift your right foot this time? Yeah, you see there's no motion. All right, and how about your left extremity now? Go ahead and lift it up. Okay, very good. All right, and so what we've done is we had a positive Tinel sign right at the common peroneal nerve, and when we tap the common peroneal nerve, he has sensation running down into a positive Tinels into the anterior cap and into the dorsum of the extensor hallucis. Is that correct, Andy?
Yes, that's
yeah.
correct.
And then also he has a area of anesthesia and paresthesia into the anterior calf at this time. And today's date is November the 24th, 08. And Andy, we'll get you walking here in just a second. Thanks. All right, Andy, go ahead and let's walk straight forward then. Okay. So we've got the typical and classic slap foot gait. Okay. Thanks, Andy. Okay. We're in the room with Andy again, and he has a tremendous recovery on the right side. Andy, go ahead and move your foot up now, the best you can. There you go. And then put it back down again, and then move it outward, sort of outward, this way. Yeah, there you go. So now he's got even more peroneal recovery than he had since he saw me last time. So, and we're real pleased with that. Okay, move both your extremities up and both your feet up. There you go. Okay, then down again. All right, 10 weeks post-op. And he's going to continue to do strengthening exercises with his therapist. Here we are 10 weeks out post-decompression of the common peroneal and of the compartment syndrome for the anterior tibial and the peroneal muscle. So Andy, let's see you walk. Excellent. Okay, Andy, turn around and go back. So now he's got dorsiflexion, almost a totally normal gait. He does weaken after a few minutes, but this activity has been within the last, I guess safely within the last 6 weeks, he's had a remarked change in function of these muscles. They're finally starting to recover. He's been on an intensive re-education program with a therapist, and he's going to continue now to strengthen these muscles and get more power so you have more longevity in his power and his function. So Andy, thanks a lot. Okay. Good morning. This is Judy Salazar. And Judy, how are you doing today?
This is the best I have felt in at least 10 years. I could not lift my foot. I could not control any of the muscles in my foot. And now I can actually bring my foot up I can move it side to side, which I was not able to do before.
Fabulous.
I do still have a little bit of the weakness in the big toe, but I can move it. And I think the more I walk with the new procedure having been done, that it'll get back to normal, what is normal for me. And I am so thankful that Dr. Parker did this for me. It's amazing. I have no tingling, no numbness, nothing anymore.
That is so nice. And we just did this last Friday, so it's been 4 days. Actually, it's just 4 days. So, and how for 10 years? This was developing for 10 years.
Yes.
Okay.
I actually had back surgery 10 years ago, and that's when the drop foot developed.
Yeah.
And I have had problems. I've had problems with it ever since.
Yeah.
And when I first came to see you, and you said that you could relieve the pressure on those two nerves, I was kind of leery, but I am so thankful that I did it, because now I can do what I used to do.
Oh, that's so good. It really made my day, Judy. And so here we have then, you had this back surgery, and of course, from our side, we're always concerned, are you going to benefit? Because if it's truly overriding the back conditions, overriding everything down here, there's little we can do frequently. But the purpose of me filming this today, and by the way, is it okay if we use this to share it with other doctors or train other doctors?
Oh, of course.
Good, thank you. And so the key here is that there are conditions, we've discussed this before, called double and triple crush, where nerves will be affected all along the chain of the nerve and not just in one place. And so if you can relieve the nerve in one or two of the other spots that's congested, then the what we call the axioplasmic flow of the nerve starts working, and you start getting function back in that.
Correct.
And this has been over 10 years, you said. Yes. That you see, and that's another thing. Would it work after 10 years? Well, if you've not had any insults by surgery or injury or anything to these areas, since that time, yes, it may relieve these and give you some benefit here. So. Once again, I appreciate you sharing your results already. I'm very, very pleased you're getting this so quickly. We will have you in some rehab.
Right.
And I know you drove 9 hours to get here from the Panhandle, but we'll get somebody up there that can start giving you rehab back home.
Okay.
And get things even stronger as the months go by.
Well, thank you.
Okay, great. Thank you. Appreciate it. We're here today with Mr. Beck. How you doing, Mr. Beck?
Just fine, thank you, sir.
Good. Mr. Beck has been kind enough to let us film his story, and you started with us in November.
Approximately, yes, sir.
Of this last year, which
Yes.
has been, November? It's been now 5 months total?
Something like that, yes.
Yes. And what I'd like for you to do is, there are so many patients that, just like you, they didn't know what to do or who could help them with their problem. And if you don't mind, if you could just start out, we started you on our neuropathy care program with the electroceuticals and the nutraceuticals, and you got some improvement. Now, would you tell us what you felt like, what your symptoms were when you first came here, how you were walking, and all that sort of thing?
Certainly.
Okay.
When I first came here, I was kind of dragging. My walk was kind of a drag. I was using a cane. I always had to hold onto the wall, be close to a wall, so that my balance was such that I wouldn't fall. That was my biggest concern. Anything that would help that was God sent. Like the Dr. Parker said, when we started my initial treatments, it wasn't very long before I could tell there was changes going on in my balance. Before, these were my toes, and I wanted to juggle my toes. I couldn't do any more than that. Now, I can do this with my toes.
And so, as I recall, I remember you specifically because I just remember what a bad shape you were in.
Yes.
And I'm just going to look at your toes now. In the very beginning, I would ask you to spread your toes, and you could not.
I could barely do about this much.
Barely
right
do
here.
them. And then, actually, with the electroceuticals, which is our German designed instrument that gives the currents to help our nerves and our circulation
Yes.
and reduce inflammation, Not too shortly after you started that, you began to get even more range of motion with your toes. Then, as I recall, you could move them more, couldn't you?
Yes, yes.
But so then, were you getting some burning and tingling at all in your feet as well, or your legs at the time?
Oh yes, I had the burning sensation. I felt, my feet felt like I had a pad about this thick underneath my feet. That was very disturbing for me. But sure enough, as the treatments went on, that pad seemed to get thinner and thinner and thinner. And if you could tell, I could wiggle my feet. Look at this.
That's
something
great.
that I could not do before. I could barely move them.
Yeah, yeah.
But above all that, my balance. I do not use a cane. I don't have to use a cane. My balance is there. My walk is about as normal as anyone. You really have to look hard to tell. I am a totally different person. Thanks to God, thanks to Dr. Parker, and the treatments that I've been receiving here at the clinic.
Thank you. And I get goosebumps when I hear these stories like this, because think of the rest of your life going the way you were going. So we did the electroceuticals and you got better. Then we evaluated. You still had some weakness in lifting your foot, right? And then did you have some tiring as well if you walked any distance still?
Sure.
Yeah.
I was able to walk. I wanted to get out and walk. As I just was so thankful that I could walk. I wanted to do, but I had to be careful that I didn't overdo it.
Yeah.
There was still a little bit of hesitation there.
Mm-hmm.
I could get tired. I would get tired.
Mm-hmm. Mm-hmm. And then we decided, though, that you still had that, so we needed to go ahead, and this was now about 3 weeks ago, that we did the common fibular release, which that helps the motor function in your foot, lifting your toes. So the thing that was so exciting to me, I remember like within the first week or two, I saw you in the hallway, and you said, "Look at me walking."
Yes.
You were doing so much better, felt so much strength.
Yes.
Is that what you're feeling now, dear Ken?
Yes, I have the strength that I never thought I was going to be able to regain that strength, and I'm just so very thankful that I have the movement. There's light at the end of the tunnel,
Yeah.
And I'm just thrilled. You have no idea how thrilled I am that I'm able to walk now. I have more confidence. There's light at the end of the tunnel.
And this Saturday, you are going to take a trip.
Yes, I thought I'd never be able to do this, but this Saturday I'm going to Israel, and there's going to be a lot of walking. I just have to listen to my body, listen to my feet, but first God, I'll be walking, and I'll be seeing those things that I've been wanting to see again, because I've been there once, but I need to go back and see everything.
Well,
And then I'll be walking through. And whenever my time is gone, I'm going to walk through those pearly gates. I will not need a cane. I will not need anything to hold me back.
Mr. Beck, you've been an absolute godsend for us as a doctor. You've been a wonderful patient. Thank you for everything you've done.
Thank you, sir. God bless.
Okay, Mr. Beck.
Which means he had 24 treatments, correct?
Very good.
No leaning, no cane. I'm going to walk through those pearly gates. Thank you, Dr. Parker.
This is Dr. Robert Parker. I hope this has been helpful in educating you as to what these modalities are and how they fit into the treatment of neuropathy. Thank you.